Question 1. A 62-year-old patient with a long-standing history of type 2 diabetes presents with a chronic non-healing ulcer on the plantar aspect of the foot. The ulcer is large with a necrotic base and moderate exudate. The patient has poor circulation and neuropathy. The wound is being treated with a hydrocolloid dressing, but after several weeks there is no improvement. Which of the following is the most appropriate next step? Management of this wound. A. Change the dressing to a foam dressing and monitor for improvement over the next several weeks. B. Initiate autolytic debridement to remove the necrotic tissue and encourage granulation tissue formation. C. Use enzymatic debridement to break down necrotic tissue and improve wound healing. D. Increase the frequency of dressing changes and keep the wound dry to prevent infection. Answer. B. Initiate autolytic debridement to remove the necrotic tissue and encourage granulation tissue formation. Explanation. In chronic wounds such as diabetic ulcers, the presence of necrotic tissue can delay healing. Autolytic debridement is an appropriate method for removing necrotic tissue in a controlled and painless manner, which is crucial for improving wound healing. This technique uses the body's natural enzymes to break down the necrotic tissue. Foam dressings, as suggested in option A, may be beneficial, but autolytic debridement is the first necessary step to promote healing. Enzymatic debridement, option C, could also be considered but is generally more aggressive. Option D, increasing the frequency of dressing changes, does not address the underlying issue of necrotic tissue and is unlikely to improve wound healing. Question 2. Mr. Taylor, a 48-year-old male with venous insufficiency, presents with a large ulcer on his lower leg. The wound has moderate exudate, a red base with some granulation tissue, and is surrounded by a well-defined area of erythema. He has been prescribed compression therapy, but the ulcer is not improving as expected. Which of the following would be the most appropriate action to take next? A. Continue compression therapy, but ensure that the dressing is changed daily to promote wound healing. B. Apply a hydrocolloid dressing to cover the wound and reduce pain during dressing changes. C. Perform sharp debridement of the wound to remove excess granulation tissue and necrotic tissue. D. Reassess the compression therapy, ensuring proper fit and pressure distribution, and consider adding a topical antibiotic to manage infection risk. Answer. D. Reassess the compression therapy, ensuring proper fit and pressure distribution, and consider adding a topical antibiotic to manage infection risk. Explanation. Venous ulcers often require compression therapy to help improve venous circulation and reduce swelling. However, incorrect application or inadequate pressure distribution can lead to suboptimal outcomes. It is essential to ensure that the compression therapy is correctly applied. In addition, antibiotics such as silver sulfate or iodine-based products may help manage infection risk if signs of infection, erythema, exudate are present. Option is not enough because it does not address potential issues with the compression therapy itself. Option B does not directly address the patient's underlying venous insufficiency, and hydrocolloid dressings are more appropriate for dry, superficial wounds. Option C, sharp debridement, would not be the first choice as there is no indication of necrotic tissue requiring removal, and the ulcer seems to be in a proliferative phase. Question 3, scenario-based. Mr. Stevens, a 75-year-old male with a history of hypertension and diabetes, is recovering from a hip replacement surgery. He presents with a surgical wound that is showing signs of dehiscence, partial opening along the incision line. The wound has moderate exudate and there is no visible infection. What would be the most appropriate action for the nurse to take in managing this wound? A. Apply a hydrocolloid dressing and continue monitoring the wound every 2-3 days for signs of infection or further dehiscence. B. Contact the surgeon immediately for potential resuturing, as dehiscence typically requires surgical intervention. C. Continue with normal dressing changes and apply a negative pressure wound therapy W, a device to promote wound closure. D. Use enzymatic debridement to address any necrotic tissue and apply a steroid dressing. Answer. C. Continue with normal dressing changes and apply a negative pressure wound therapy W, a device to promote wound closure. Explanation. In the case of surgical wound dehiscence, Debuin help facilitate wound closure by applying controlled negative pressure to remove excess exudate, improve blood flow to the wound, and promote tissue regeneration. This technique is particularly effective for wounds that are not infected and have partial opening. Option is insufficient because it does not address the underlying issue of wound dehiscence and is more appropriate for superficial wounds without complications. Option B is unnecessary unless there is a significant infection or large gap that cannot be managed conservatively. Option D suggests enzymatic debridement, which is more suitable for necrotic wounds, but dehiscence in a post-surgical wound typically does not require debridement unless necrosis is present. Question 4. A 55-year-old woman with a history of venous insufficiency presents with a large, irregular-shaped ulcer on her lower leg. The wound has heavy exudate, a red base, and surrounding skin is discolored with signs of mild edema. After assessing the wound, you determine that the patient requires compression therapy. Which of the following would be the most appropriate approach to manage this patient's wound? A. Apply a hydrocolloid dressing and monitor the wound for any signs of infection. B. Begin compression therapy using a multi-layer bandage system to promote venous return and reduce swelling. C. Use a foam dressing and apply compression stockings for daily management. D. Apply a silver sulfadazine dressing and a compression wrap to treat infection and support healing. Answer: B. Begin compression therapy using a multi-layer bandage system to promote venous return and reduce swelling. Explanation: venous ulcers, which are common in patients with venous insufficiency, require compression therapy to reduce edema and promote venous return. A multi-layer compression bandage system is often the most effective option in managing these types of ulcers. The hydrocolloid dressing in option is more appropriate for non-exudative wounds and would not address the underlying venous insufficiency. Option C, while using compression stockings, does not provide adequate compression for active ulcers, especially larger or deeper wounds. Option D, although silver sulfadazine is used for infection control, is not the best option for this patient since the ulcer's primary issue is venous insufficiency and not infection. Question 5. A 67-year-old male patient is being treated for a diabetic foot ulcer. The wound is showing signs of chronicity, with a significant amount of necrotic tissue at the base, moderate exudate, and a foul odor. The wound has not responded to previous treatment using hydrocolloid dressings. What is the next appropriate step in managing this wound? A. Increase the frequency of hydrocolloid dressing changes. B. Perform sharp debridement to remove the necrotic tissue and promote granulation. C. Switch to a foam dressing to help absorb exudate and promote healing. D. Apply a biological dressing to cover the wound and promote new tissue growth. Answer: B. Perform sharp debridement to remove the necrotic tissue and promote granulation. Explanation: for chronic diabetic foot ulcers with necrotic tissue, sharp debridement is essential to remove dead tissue that could impede healing. By removing the necrotic tissue, you allow healthy granulation tissue to form and promote better wound healing. Option A, increasing the frequency of hydrocolloid dressing changes, would not address the issue of necrotic tissue, which is a primary cause of delayed healing. Option C, switching to a foam dressing, is a helpful dressing choice for highly exudative wounds but does not address the underlying issue of necrotic tissue. Option D, biological dressings could be considered, but sharp debridement should be prioritized to improve wound conditions first. Question 6. MS Jones, a 78-year-old female, presents with a stidham and tuescher injury on her sacrum. The wound is shallow with partial thickness loss of skin and the base is pink and moist. The surrounding skin is intact and there are no signs of infection. What would be the most appropriate treatment for this wound? A. Apply a hydrocolloid dressing and perform daily dressing changes. B. Use a hydrocolloid dressing and implement regular repositioning to relieve pressure. C. Apply a foam dressing and restrict patient movement to avoid pressure on the wound. D. Use a sterile gauze dressing and increase the frequency of repositioning. Answer: B. Use a hydrocolloid dressing and implement regular repositioning to relieve pressure. Explanation: Nittigium and tuescher injuries involve partial thickness loss of skin, and hydrocolloid dressings are ideal because they provide a moist environment which promotes healing while offering protection against contamination. Repositioning the patient regularly is crucial to relieve pressure on the affected area, as this is the primary cause of the wound. Option is a good choice for treating a stidham and tuescher injury, but repositioning is a critical element that cannot be overlooked. Option C would unnecessarily restrict patient movement, which is not an effective treatment. Option D suggests gauze, which is less ideal than a hydrocolloid dressing for maintaining a moist healing environment, and while repositioning is essential, restricting movement can cause more harm than good. Question 7. A patient with chronic kidney disease presents with an ulcer on his foot that has not healed over the last few months. The wound has a thick white exudate and there are signs of a bacterial biofilm. The wound is painful and inflamed with surrounding erythema. Which of the following is the most appropriate course of action? A. Begin enzymatic debridement and apply a hydrocolloid dressing to promote healing. B. Use a negative pressure wound therapy, W, a device to help remove exudate and reduce inflammation. C. Administer systemic antibiotics and debride the wound to remove the biofilm. D. Apply a silver-based dressing to combat infection and provide a moist environment. Answer. C. Administer systemic antibiotics and debride the wound to remove the biofilm. Explanation. Bacterial biofilm, which can form in chronic wounds, significantly impairs wound healing and increases the risk of infection. The most effective management includes both systemic antibiotics to address the infection and sharp debridement to remove biofilm and necrotic tissue. Option A. Enzymatic debridement could be helpful for necrotic tissue but is not as effective against biofilm. Option B. W is used for wounds with excessive exudate but would not resolve the biofilm issue. While silver-based dressings in option D are beneficial for infection control, they are not sufficient in treating biofilm, which requires more aggressive interventions such as debridement and systemic antibiotics. Question 8. A 52-year-old patient with peripheral artery disease presents with a dry, painful ulcer on the dorsum of the foot. The wound is well defined with a necrotic base and there is no exudate. The surrounding skin is pale and cool to touch. Which of the following would be the most appropriate treatment for this type of wound? A. Apply a hydrocolloid dressing and administer topical antibiotics. B. Use a hydrogel dressing to maintain moisture and promote healing. C. Begin compression therapy and apply a foam dressing for exudate management. D. Apply a sterile gauze dressing and elevate the affected limb to reduce ischemia. Answer. B. Use a hydrogel dressing to maintain moisture and promote healing. Explanation. For arterial ulcers, which are caused by poor circulation, the goal is to maintain a moist environment that supports healing while minimizing infection risk. Hydrogel dressings are ideal for dry, necrotic wounds as they help provide moisture to the wound bed, promoting autolytic debridement. Compression therapy, option C, would not be appropriate. Arterial ulcers because it could exacerbate ischemia. Option D, while elevating the limb is beneficial for improving circulation, does not address the need for wound moisture and debridement. Option A, although hydrocolloid dressings are good for exudative wounds, is not the best choice for dry, necrotic arterial ulcers. Question 9. A 68-year-old woman with a history of obesity and type 2 diabetes presents with a large ulcer on her medial ankle. The wound is deep with exposed tendon and shows signs of infection with purulent drainage. The patient reports increased pain and difficulty walking. What is the most appropriate initial management strategy for this wound? A. Perform sharp debridement, apply a hydrocolloid dressing and begin systemic antibiotics. B. Apply a foam dressing, elevate the leg and initiate local wound care with antiseptic solution. C. Initiate systemic antibiotics, perform sharp debridement to remove necrotic tissue and use E. Begin compression therapy and use a silver sulfadiazine dressing to control infection. Answer. C. Initiate systemic antibiotics, perform sharp debridement to remove necrotic tissue and use eau de vie. Explanation. For deep, infected ulcers, especially those with exposed tendons, the primary goals are infection control and debridement. Systemic antibiotics are necessary to treat the infection, and sharp debridement will remove necrotic tissue, allowing healthy tissue to regenerate or be beneficial in managing exudate, reducing the risk of further tissue damage, and promoting wound closure. Option. The focus is too much on dressing changes and does not adequately address infection control or the need for debridement. Option B does not address the infection sufficiently, and option D, while silver sulfadiazine is useful in some infections, does not address the need for systemic antibiotics and aggressive wound management. Question 10. A 45-year-old diabetic patient presents with a chronic wound on the plantar surface of his foot near the heel. The wound is large with a sloughy base and moderate exudate. The patient has poor glycemic control and the wound has shown minimal progress in healing over the last several months. Which of the following is the best approach for managing this wound? They apply a foam dressing and begin a topical antimicrobial agent to control infection. B. Use a hydrocolloid dressing and monitor the wound for any changes. C. Begin sharp debridement of the sloughy tissue, control the patient's blood sugar and use a moisture-retentive dressing. D. Initiate systemic antibiotics and use a silver-based dressing to control infection. Answer: C. Begin sharp debridement of the sloughy tissue, control the patient's blood sugar and use a moisture-retentive dressing. Explanation: for chronic diabetic foot ulcers, it is critical to perform sharp debridement to remove sloughy tissue, which can prevent healing. Additionally, glycemic control is a key factor in promoting wound healing in diabetic patients. Moisture-retentive dressings like hydrocolloids or foams should be used to maintain optimal healing environment, while systemic antibiotics, option D, might be necessary if infection is present. This patient's wound is primarily hampered by non-healing slough and poor glycemic control. Option is a reasonable approach but does not address the root causes of the wound's chronicity, and option B is insufficient given the sloughy base and lack of healing. Question 11. A 60-year-old patient with a history of hypertension and smoking presents with a non-healing ulcer on the lateral aspect of her lower leg. The ulcer is shallow, has a clean pink base, and is surrounded by hyperpigmented skin. There is minimal exudate, and the patient reports intermittent pain at the wound site. What is the most likely cause of this wound? A. Venous insufficiency. B. Arterial insufficiency. C. Pressure injury. D. Diabetic neuropathy. Answer A. Venous insufficiency. Explanation: the most likely cause of this wound is venous insufficiency, which often presents with shallow ulcers on the lower leg, particularly on the medial or lateral aspect. These ulcers are typically surrounded by hyperpigmented skin and may have a pink base. Pain may be intermittent and related to venous congestion. In contrast, arterial insufficiency, option B, typically results in deeper, more painful ulcers with a neck base. Pressure injuries, option C, typically occur over bony prominences and are associated with prolonged pressure. Diabetic neuropathy, option D, often results in painless neuropathic ulcers typically located on the plantar surface of the foot. Question 12. A 72-year-old male with a history of peripheral vascular disease presents with an ischemic ulcer on his toe. The ulcer is painful with a dry, black necrotic base and no signs of infection. The surrounding skin is cool to touch and the pulses in the foot are weak. What is the most appropriate first step in managing this ulcer? A. Initiate systemic antibiotics and debride the necrotic tissue. B. Apply a hydrocolloid dressing to maintain moisture and promote healing. C. Refer for revascularization to restore blood flow to the affected area. D. Begin compression therapy to improve circulation and reduce edema. Answer C. Refer for revascularization to restore blood flow to the affected area. Explanation: in patients with ischemic ulcers, particularly those caused by peripheral vascular disease, the most important initial step is to restore blood flow to the affected area. Revascularization, either through surgery or other interventions, is crucial for healing and preventing further tissue loss. Option is incorrect because infection is not currently present and systemic antibiotics are not indicated. Option B is not appropriate for an ischemic ulcer with a dry necrotic base, as moisture-retentive dressings are more effective on wounds with granulating tissue. Option D, compression therapy would not be appropriate in ischemic ulcers as it could exacerbate the condition by further restricting blood flow. Question 13. A 50-year-old woman presents with a pressure injury on her coccyx. The wound is deep with full-thickness skin loss, and the underlying tissue is exposed. There is a moderate amount of exudate, and the wound appears to be progressing slowly in healing. What is the most appropriate dressing to promote optimal healing for this type of wound? A. Foam dressing to manage exudate and protect the wound. B. Hydrocolloid dressing to provide a moist healing environment. C. Alginate dressing to absorb exudate and promote hemostasis. D. Gauze dressing with a topical antimicrobial agent to control infection. Answer A. Foam dressing to manage exudate and protect the wound. Explanation: for a deep, full-thickness pressure injury with moderate exudate, a foam dressing is the most appropriate choice. Foam dressings effectively manage exudate, protect the wound from external contaminants, and provide a moist environment that supports healing, while hydrocolloids, option B, are also good for providing a moist environment. They are not as effective in high levels of exudate. Alginate dressings, option C, are often used for wounds with heavy exudate, but are less appropriate for deeper wounds like this one. Gauze dressings, option D, can cause trauma during dressing changes and do not provide as optimal a healing environment as foam or hydrocolloid dressings. Question 14. A 70-year-old male patient with a history of uncontrolled diabetes and peripheral neuropathy presents with a plantar ulcer on his foot. The wound is painless, has a thick callus around the edges, and the surrounding skin is dry. The ulcer shows no signs of infection, but the patient reports difficulty with mobility due to discomfort in the area. What is the most likely cause of this ulcer? A. Neuropathic ulceration due to diabetic peripheral neuropathy. B. Venous stasis, ulcer due to chronic venous insufficiency. C. Arterial ulceration due to peripheral arterial disease. D. Pressure injury due to prolonged pressure on the foot. Answer A. Neuropathic ulceration due to diabetic peripheral neuropathy. Explanation. This patient most likely has a neuropathic ulcer, which is common in individuals with uncontrolled diabetes and peripheral neuropathy. Neuropathic ulcers are typically painless, occur on weight-bearing areas of the foot, like the plantar surface, and may be surrounded by a thick callus. The absence of infection and the dry skin suggest that the wound is not venous or arterial. Origin: venous ulcers, option B, and arterial ulcers, option C, typically cause pain, and pressure injuries, option D, usually found over bony prominences rather than on the plantar surface. Question 15. A 55-year-old male with a history of hypertension and smoking presents with an ulcer on his lower leg. The wound is deep, has a pale, dry base, and there is no exudate. The surrounding skin is cool to touch and pulses in the foot are weak. What is the most likely cause of the ulcer? A. Venous insufficiency. B. Arterial insufficiency. C. Diabetic neuropathy. D. Pressure injury. Answer B. Arterial insufficiency. Explanation. This patient's wound is most likely caused by arterial insufficiency indicated by the deep ulcer with pale, dry base and the weak pulses in the foot. Arterial ulcers typically occur on the toes, feet, or lower legs and are associated with poor peripheral circulation. The cool surrounding skin also points toward poor blood flow. Venous insufficiency, option A, would generally present with shallower wound, more exudate, diabetic neuropathy. Option C typically results in painless ulcers, but the wound characteristics here, dry, pale, no exudate, are more consistent with arterial insufficiency. Pressure injuries, option D, are typically found over bony prominences. Question 16. A 40-year-old woman with a history of venous insufficiency presents with a large, irregular wound on the medial aspect of her lower leg. The wound has a red, granular base and moderate exudate. The surrounding skin is pigmented in edematous. What is the best initial approach to managing this wound? A. Apply a hydrocolloid dressing and elevate the leg to reduce edema. B. Begin sharp debridement and apply an alginate dressing to absorb exudate. C. Use compression therapy to promote venous return and reduce swelling. D. Apply a foam dressing to maintain moisture and control exudate. Answer C. Use compression therapy to promote venous return and reduce swelling. Explanation. The most appropriate treatment for a venous ulcer is compression therapy, which helps to reduce edema, promote venous return, and improve circulation. This is the cornerstone of management for venous ulcers, as the condition is often caused by poor venous circulation. Option is not sufficient without compression therapy for venous insufficiency. Sharp debridement, option B, may be necessary if necrotic tissue is present, but this ulcer does not appear to have slough or necrosis. Option D, foam dressing, is useful for managing exudate but should be used in conjunction with compression therapy in venous ulcers. Question 17. A 60-year-old diabetic male presents with a wound on the plantar surface of his foot. The ulcer is painless, has a well-defined edge, and is surrounded by callous tissue. The wound has no signs of infection but has not healed over the past few months. What is the most appropriate first step in the management of this wound? A. Perform sharp debridement and provide offloading. B. Apply a hydrocolloid dressing and monitor for infection. C. Administer systemic antibiotics to prevent infection. D. Perform a skin graft to promote healing. Answer A. Perform sharp debridement and provide offloading. Explanation. The most appropriate first step in managing a neuropathic diabetic ulcer is to perform sharp debridement to remove any callous and non-viable tissue that may be impeding healing. Offloading through the use of specialized footwear or pressure-reducing devices is also crucial in preventing further pressure on the ulcer. Hydrocolloid dressings, option B, may be used after debridement, but they are not a first-line treatment. Systemic antibiotics, option C, are not needed unless there are signs of infection, which are not present in this case. Skin grafting, option D, may be considered later, but initial management should focus on debridement and offloading. Question 18. A 70-year-old female with a history of peripheral arterial disease presents with a non-healing wound on her foot. The wound is located on the dorsum of the foot, is painful, has a necrotic base, and shows no signs of infection. The surrounding skin is pale and cold. What is the best management strategy for this wound? A. Apply a silver-based dressing and provide systemic antibiotics. B. Refer for surgical consultation to evaluate for revascularization. C. Apply a foam dressing to manage exudate and promote healing. D. Initiate compression therapy to improve circulation. Answer. B. Refer for surgical consultation to evaluate for revascularization. Explanation. This patient is presenting with a wound likely caused by poor arterial circulation, indicated by the pale cold skin and the necrotic base of the wound. In such cases, the most appropriate management is to refer the patient for revascularization to restore blood flow, which is critical for healing. Silver-based dressings, option A, may help prevent infection but will not address the underlying circulatory issue. Foam dressings, option C, are more appropriate for wounds with granulating tissue and exudate, not necrotic wounds caused by arterial insufficiency. Compression therapy, option D, would not be appropriate for arterial ulcers, as it could further compromise blood flow. Question 19. A 60-year-old woman presents with a stage 2 pressure injury on her sacrum. The wound is shallow with a red, moist base and no necrosis. The surrounding skin is intact but shows signs of erythema. What is the most appropriate treatment for this wound? A. Apply a foam dressing to provide a moist healing environment. B. Use a hydrocolloid dressing to absorb, exudate and promote healing. C. Apply a gauze dressing and monitor for infection. D. Initiate systemic antibiotics to prevent infection. Correct answer. B. Use a hydrocolloid dressing to absorb, exudate and promote healing. Explanation. 4. A stage 2 pressure injury, which is characterized by partial thickness skin loss, the most appropriate treatment is a hydrocolloid dressing. These dressings help to absorb, exudate, provide a moist healing environment, and protect the wound from external contaminants. Foam dressings, option A, are typically more appropriate for deeper wounds. Significant exudate. Gauze dressings, option C, can cause trauma during dressing changes and are less ideal for promoting a moist healing environment. Systemic antibiotics, option D, are not necessary unless signs of infection are present, which is not the case in this scenario. Question 20. A 75-year-old male with a history of chronic venous insufficiency presents with a large ulcer on his lower leg near the medial malleolus. The wound has a shallow base with moderate serous exudate and the surrounding skin is erythematous and edematous. What is the most appropriate treatment for this type of ulcer? A. Compression therapy to improve venous return and reduce swelling. B. Apply a hydrocolloid dressing to promote moisture balance. C. Administer systemic antibiotics to prevent infection. D. Use a vacuum-assisted closure (VAC) device to accelerate healing. Answer. A. Compression therapy to improve venous return and reduce swelling. Explanation. For ulcers caused by venous insufficiency, the most important treatment is compression therapy. It helps to reduce edema, enhance venous return, and improve circulation, all of which are essential for healing. Hydrocolloid dressings, option B, can help with wound moisture balance, but are not the first-line treatment for venous ulcers where compression is crucial. Antibiotics, option C, are only necessary if infection is suspected. A VAC device, option D, is typically used for deep or chronic wounds, but is not the first choice for venous ulcers. Question 21. A 50-year-old diabetic male presents with a foot ulcer that has been present for 3 weeks. The ulcer is painless, has well-defined edges, and is located on the plantar surface of the foot. The base is granular and red, and there is moderate exudate. What is the most appropriate treatment plan for this ulcer? A. Apply a dry gauze dressing and elevate the leg. B. Use a hydrocolloid dressing and offload the foot. C. Begin systemic antibiotics to prevent infection. D. Perform surgical debridement and consider a skin graft. Answer. B. Use a hydrocolloid dressing and offload the foot. Explanation. For diabetic ulcers, especially those on the plantar surface, the key treatment is offloading the foot to reduce pressure. Hydrocolloid dressings, option B, provide a moist healing environment, which is ideal for promoting granulation tissue. Dry gauze, option A, can dry out the wound, potentially delaying healing. Systemic antibiotics, option C, are not indicated unless the signs of infection, which are not present in this case. Surgical debridement, option D, is unnecessary at this stage unless there is necrotic tissue. Question 22. A 45-year-old male with a history of hypertension and hyperlipidemia presents with a non-healing ulcer on his lower leg. The wound is deep with a yellow, sloughy base and there is no significant exudate. The surrounding skin is cool and the pedal pulses are weak. What is the most likely cause of the ulcer? A. Venous insufficiency. B. Arterial insufficiency. C. Diabetic neuropathy. D. Pressure injury. Answer: B. Arterial insufficiency. Explanation: this patient is presenting with a deep wound with a sloughy base, which is more characteristic of an arterial ulcer. The cool surrounding skin and weak pedal pulses further suggest poor arterial circulation. Venous ulcers, option A, are more superficial and often have a different presentation. Diabetic neuropathy, option C, typically results in painless shallow ulcers on the feet, not deep wounds with slough. Pressure injuries, option D, are typically found over bony prominences and have a different appearance. Question 23. A 65-year-old woman presents with a painful ulcer on the lateral aspect of her foot. The ulcer is small with a punched-out appearance and the surrounding skin is pale and cool. The patient has a history of smoking and diabetes. What is the most likely etiology of this wound? A. Arterial insufficiency. B. Venous insufficiency. C. Diabetic neuropathy. D. Pressure injury. Answer: A. Arterial insufficiency. Explanation: the presentation of a small, punched-out ulcer with pale and cool skin suggests an arterial insufficiency ulcer, which typically results from poor blood flow to the area. The patient's history of smoking and diabetes increases the likelihood of arterial disease. Venous insufficiency, option B, typically causes more superficial, irregularly shaped ulcers. Diabetic neuropathy, option C, can lead to foot ulcer, but these are usually painless and lack the characteristics of an arterial ulcer. Pressure injuries, option D, are usually seen over bony prominences. Question 24. A 68-year-old female with a history of heart failure presents with a leg ulcer on the medial aspect of her lower leg. The wound is shallow with a moist, red base and moderate exudate. The surrounding skin is erythematous and there is significant edema. What is the most appropriate first step in the management of this wound? A. Apply a hydrocolloid dressing and monitor for infection. B. Begin compression therapy to reduce edema and promote venous return. C. Administer systemic antibiotics for infection control. D. Perform sharp debridement to remove necrotic tissue. Answer: B. Begin compression therapy to reduce edema and promote venous return. Explanation: for venous ulcers, compression therapy is the most important first step to reduce swelling, enhance venous return, and improve circulation. The erythematous surrounding skin and significant edema point to venous insufficiency. Hydrocolloid dressings, option A, may help maintain moisture but are secondary to compression therapy and venous ulcer management. Antibiotics, option C, are unnecessary unless signs of infection are present. Sharp debridement, option D, is not needed at this stage unless there is necrosis or slough. Question 25. A 56-year-old female presents with a large, painful wound on her sacrum, which developed after a prolonged stay in a nursing home. The wound has a dark, necrotic base and the surrounding skin is red, warm, and swollen. The patient has a history of immobility due to arthritis and is on a regular medication regimen that includes corticosteroids. What is the most likely etiology of this wound? A. Diabetic foot ulcer. B. Pressure injury. C. Arterial insufficiency ulcer. D. Venous insufficiency ulcer. Answer: B. Pressure injury. Explanation: the location of the wound on the sacrum and the patient's history of immobility and prolonged pressure exposure make this wound most likely pressure injury. Option B. Pressure injuries commonly develop in patients with limited mobility, especially over bony prominences such as the sacrum. The necrotic base and erythematous surrounding skin are also consistent with stid-Rome pressure injury. Diabetic ulcers, option A, are typically located on the plantar surface of the foot, while arterial ulcers, option C, are usually found on the lower extremities and have different presentation. Venous ulcers, option D, are also located on the lower legs, but have more irregular border and less necrotic tissue. Question 26. A 72-year-old male with a history of uncontrolled diabetes and peripheral neuropathy presents with a foot ulcer that has been present for 6 weeks. The wound has A dry, leathery eschar with minimal exudate. There are no signs of infection, but the patient reports decreased sensation in the affected foot. What is the most appropriate initial step in the management of this wound? A. Apply a hydrocolloid dressing and offload the foot. B. Begin systemic antibiotics to prevent infection. C. Perform surgical debridement to remove the eschar. D. Use a negative pressure wound therapy W device. Answer A. Apply a hydrocolloid dressing and offload the foot. Explanation. For diabetic foot ulcers, especially those with a dry eschar and minimal exudate, the first step should be offloading the foot to relieve pressure and applying a hydrocolloid dressing to maintain a moist wound environment, which facilitates healing. Systemic antibiotics, option B, are unnecessary unless there is evidence of infection, which is not present here. Surgical debridement. Option C is not indicated unless there is necrotic tissue that cannot be managed with dressing changes. Negative pressure wound therapy option D is generally reserved for larger or deeper wounds, not for ulcers with minimal exudate and a dry eschar. Question 27. A 62-year-old male with a history of venous insufficiency presents with an ulcer on the lower leg. The wound has a shallow base with red, granulating tissue, and there is significant edema and venous stasis changes in the surrounding skin. What is the most appropriate dressing choice for this wound? A. Hydrogels to maintain moisture balance. B. Foam dressing to absorb exudate and provide cushioning. C. Alginate dressing to promote hemostasis. D. Dry gauze dressing to prevent infection. Answer B. Foam dressing to absorb exudate and provide cushioning. Explanation. For venous ulcers, foam dressings are the most appropriate choice as they provide cushioning and absorb moderate to heavy exudate while protecting the wound from further trauma. The granulating tissue suggests that the wound is in the proliferative phase, and foam dressings will help maintain a moist environment conducive to healing. Hydrogels, option A, are better for dry wounds, not appropriate for wounds with moderate to heavy exudate. Alginate dressings, option C, are suitable for highly exudative wounds, but not ideal for venous ulcers with moderate exudate. Dry gauze, option D, is less effective at managing exudate and may dry out the wound, impairing healing. Question 28. A 45-year-old female presents with an ulcer on her lower leg that has been present for several months. The ulcer has irregular borders and is surrounded by dark, discolored skin. The wound bed has yellow, slow and moderate exudate. The patient has a history of hypertension and diabetes. What is the most likely type of ulcer? A. Venous ulcer. B. Arterial ulcer. C. Diabetic neuropathic ulcer. D. Pressure injury. Answer A. Venous ulcer. Explanation. The presentation of an irregularly shaped wound with yellow slough and moderate exudate, along with surrounding skin discoloration, is most consistent with a venous ulcer. Venous ulcers are often found on the lower leg, especially around the medial malleolus, and are associated with venous stasis and impaired circulation. Arterial ulcers, option B, typically have a punched-out appearance with a dry, pale wound bed. Neuropathic ulcers, option C, are usually painless and located on the plantar surface of the feet. Pressure injuries, option D, occur over bony prominences and are usually not surrounded by the same discoloration seen in venous ulcers. Question 29. A 60-year-old male with a history of hypertension and hyperlipidemia presents with a painful wound on his foot. The wound has a well-defined edge, and the surrounding skin is cool to the touch. The patient reports intermittent claudication and a history of smoking. What is the most likely cause of the wound? A. Venous insufficiency. B. Arterial insufficiency. C. Diabetic neuropathy. D. Pressure injury. Answer B. Arterial insufficiency. Explanation. This patient's wound, located on the foot with cool surrounding skin, is most likely caused by arterial insufficiency. The patient's history of intermittent claudication, smoking, and hyperlipidemia also suggests poor arterial circulation, which can lead to ischemic ulcers. Venous insufficiency, option A, typically presents with shallow, irregularly shaped ulcers and is less likely to cause cool surrounding skin. Diabetic neuropathy, option C, can lead to ulcers, but these are typically painless and located on the feet or toes. Pressure injuries, option D, occur over bony prominences and are unlikely to be the cause in this case. Question 30. A 75-year-old woman with a history of diabetes presents with an ulcer on the bottom of her foot. The ulcer is deep with exposed bone and a foul odor. There is no pain due to diabetic neuropathy. What is the most appropriate management step for this ulcer? A. Apply a hydrocolloid dressing and monitor for signs of infection. B. Administer systemic antibiotics and debride necrotic tissue. C. Offload the foot and apply a foam dressing. D. Apply a silver sulfadiazine dressing to prevent infection. Answer B. Administer systemic antibiotics and debride necrotic tissue. Explanation. This diabetic foot ulcer with exposed bone and a foul odor is likely infected and requires systemic antibiotics and debridement of necrotic tissue. Option B. The foul odor suggests that there may be an active infection, and the exposed bone increases the risk of osteomyelitis. Hydrocolloid dressings, option A, are not appropriate for deep infected wounds. Offloading the foot, option C, and applying a foam dressing may be part of later management but do not address the infection. Silver sulfadiazine, option D, is useful for burn wounds but is not the first choice for infected diabetic ulcers, especially with exposed bone.